This is Dr. Hessel dictating the second part of my podcast on cardiovascular monitoring for the new residents. We've gone over the reading assignments in the past. For this part, I'm going to talk about these three topics. The pulmonary artery catheter refers to a balloon-tipped pulmonary catheter developed by engineers at Edwards Laboratory under the leadership of Dr. Swan and Gans at Cedars-Sinai Hospital. It was first introduced in 1972. It's more appropriately called a pulmonary artery or a balloon-tipped flow-directed pulmonary catheter, but often referred to as a Swan or a Swan-Gans catheter. As you know, it consists of a long, thin catheter with a inflatable balloon at its tip. This is a picture of one of these catheters, and it has marks on it at various distances. One mark being 10 centimeters, 2, 3, and then when it gets to 50, it's a solid line, and then 60, 70, 80, 90, and 100. It has a red lumen here to fill the balloon and multiple other lumens for other purposes. It is introduced into a central venous line, subclavian or IJ, into the right atrium, and then the balloon is inflated and it follows the flow of blood gradually into the right atrium, and then through the tricuspid valve into the right ventricle, and then through the pulmonary valve into the pulmonary artery, and then eventually wedges into a small pulmonary artery. As I indicated, eventually it goes further out until it occludes a small pulmonary artery, allowing measurement of the distal pressure, which is called a wedge pressure, which reflects the left atrial pressure. When it's in the wedge position, it acts like a water manometer and allows one to assess the left atrial pressure, which is really why Swan invented this. Once it is in the wedge position, you then deflate the balloon, and now it's in the pulmonary artery. And then whenever you want to know what the pressure is on the left side, you simply inflate the balloon. The advantage of this catheter is that it can be placed without use of fluoroscopy. This is why Swan and Gans invented it. So you simply watch the pressure waves, and when you're in the right atrium, you see a venous wave. When it gets into the right ventricle, you see a ventricular wave. When it gets into the PA, you see a pulmonary artery wave, and then when it wedges, you see a wedge trace. Now, the advantage when this was introduced, it allowed clinicians for the first time to evaluate the pressure in the left heart, and it revolutionized clinical care of patients. But besides measuring these pressures, it also can measure blood temperature, mixed venous saturation, and also cardiac output. This is allowed by these multifunctional catheters. Many companies make them. The ones we use here at UK is by Edwards, called the combo catheter. It has multi-lumens. It's quite miraculous that they can put so many lumens in a 8.5 French catheter. It does have a latex balloon, which is important to know. They used to have heparin coated, but they're no longer heparin coated. And then they're connected to a box, which provides you with all this important information. This summarizes the information that is provided by the modern pulmonary artery catheter. These are the direct information it provides, but it can also be used to calculate cardiac index, stroke volume, systemic vasoresistance, pulmonary vasoresistance, oxygen delivery and extraction, and the presence of shunts. In the past, clinicians used it to estimate LV preload, i.e. filling. But just like for central venous pressure, the static pulmonary artery occlusion pressure is misleading estimate of filling pressures, especially to fluid responsiveness. This was a weak use of the pulmonary artery catheter. It was not a fault of the developers of the catheter, but of how people used it. But it's taken a long time for people to realize that the wedge pressure didn't definitely tell you how fluid loaded or unloaded the patient was. On the other hand, there are many reasons why you ought to be interested in the wedge pressure. It gives you a clue to LV function, to detect myocardial ischemia, to evaluate mitral valve function, to give you a clue to the risk of pulmonary edema, to understand the pathophysiology of pulmonary edema. Remember, is it due to hydrostatic or permeability problems? And to understand the pathophysiology of pulmonary hypertension. Is it due to increased pulmonary venous pressure, increased flow, or increased pulmonary vasoresistance? And it's also helpful in assessing the response to fluid challenge. When you give a fluid challenge, does it adversely affect filling pressures or cardiac output? It also uniquely provides an easy way of assessing cardiac output. There are two methods, either the intermittent bolus technique or the continuous technique. In our operating rooms, we use the continuous technique. Thermodilution cardiac output is considered the clinical gold standard for measuring cardiac output. And we'll come back to this topic a little bit later. By thermodilution, they inject a known amount of heat or cold into the right side of the heart and measure the effect on pulmonary artery temperature. It should be obvious to you that this effect on pulmonary artery temperature is inversely proportional to cardiac output. In fact, the cardiac output may be calculated exactly by dividing the amount of heat added by the area in the temperature change. And this is how it's measured by this method. Remember, however, it's actually measuring pulmonary blood flow. Now, normally, this is the same as systemic cardiac output, and so we tend to consider it a measurement of cardiac output. But remember, we're assuming that these are the same, and in the presence of shunt, that would not be true. Finally, unfortunately, it's invalidated by severe tricuspid regurgitation, which is not rare in some of our patients. A third parameter that the pulmonary artery catheter gives us is the mixed venous oxygen. This is best determined by measuring the concentration of oxygen in the blood in the pulmonary artery, and is a major use of pulmonary artery catheter. It gives us a clue of the adequacy of cardiac output, more precisely the adequacy of oxygen delivery compared to the oxygen needs, i.e. the balance of oxygen delivery to oxygen demand. Delivery comes in, it's consumed by the body, and what is left is the mixed venous. The mixed venous gives us the ratio of delivery to demand. Normally, the mixed venous saturation is about 75%. When the consumption increases, oxygen delivery normally increases and venous saturation stays the same. Conversely, when consumption decreases, oxygen delivery decreases and the consumption stays the same. Thus, if mixed venous oxygen is less than 70, and certainly if it's less than 60, and obviously if it's less than 50, this suggests that supply is not meeting demand. It could be due to inadequate supply, or it could be due to excess demand. Normally, the body should match increased demand by increasing supply. But in patients with limited heart, lung, or volume status, they may be unable to compensate. Low mixed venous oxygen is always abnormal. Unfortunately, a normal or high doesn't always assure that all is well. There are other applications of the mixed venous oxygen, which I have summarized on this slide. Finally, like everything we do in medicine, there are complications. These can be summarized by when they occur. They occur during central venous access, and we've already reviewed these complications. They occur while they're indwelling, and these include arrhythmias, coiling, perforations. Other complications are summarized on this slide. Finally, there are risks associated with its removal. The corollary is when you're removing PA catheters, the patient should be in the Trendelenburg position. You should cover the end of the introducer with your finger. You should cap and seal the end of the introducer, and you should not replace the guide wire or a smaller catheter. The good news is the incidence of complications is relatively rare. Not zero, but quite low, and the incidence of death is nearly zero. There are a few absolute contraindications and a number of relative complications that you should be aware of. However, recent data have questioned the traditional indications. These are a number of randomized controlled trials. The good news was that they were not associated with increased risk, but the bad news is they were not associated with lower risk. As a consequence, there has been a marked decrease in the use of pulmonary artery catheters over the last few years. However, I believe that they should remain in our monitoring armamentarium during anesthesia and critical care, because they can provide unique information in a rapid and reliable and online format, often continuous, with little requirements on the part of the practitioner. The information can assist with the diagnosis of hemodynamic abnormalities and help explain important abnormalities. It can also guide and evaluate hemodynamic interventions and guide with fluid assessment. It can provide unique information in the most accurate or convenient format. Cardiac output, mixed venous oxygen, pulmonary artery saturation, and pulmonary artery occlusion pressure. These are not available by any other methods as accurately. So my suggestion is to use them in complex cases with confusing pathophysiology or who are not responding to conventional therapy. Patients with cardiogenic shock, septic shock, for the differential diagnosis of pulmonary edema, in patients with severe heart disease, in patients with severe trauma, and patients with pulmonary hypertension and right heart failure. But there are limitations. You must obtain accurate information. You must interpret and act on it promptly. You cannot use static filling pressures alone to assess volume. It's just one tool. You must integrate it with other information and be quick to add echocardiography. Reserve it for the sickest patients. Have well-defined goals and rationale. Initiate early. Get accurate data. Interpret it appropriately. Act rationally. And remove the catheter as soon as possible. Let me then turn to a topic we've already talked about, namely monitoring cardiac output. There are many reasons why we are interested in cardiac output, and I'm sure you are aware of all of these. There are many ways to assess cardiac output. Usually we do it clinically, and you are well familiar with these. The problem is that even experts are wrong up to 50% of the time. The gold standard is the fixed cardiac output, but this is not readily measured in the operating room. The mixed venous oxygen gives you a ratio of supply and demand. A pulse wave analysis is commonly used, but not very accurate in sick patients. There are some other less invasive methods that are described, which are beyond our presentation today. But the clinical gold standard is the indicator dilution technique that we've just described using thermal dilution. Important is, what is normal cardiac output? If I asked you, you would all say 5 to 7 liters per minute. But this depends on many important variables. One is body size, and for this we tend to adjust it to body surface area. And normal cardiac index is 3.5 liters per minute per meter squared. It's also influenced by age, and as you get older, normal gradually lowers. It also changes with stress, and with stress of trauma, surgery, burn, sepsis, ARDS, it is normally increased. Conversely, with anesthesia, it tends to decrease. And finally, it's proportional to temperature. All of these suggest that the principal determinant of normal cardiac output in a patient is their oxygen demand. Normally, the body adjusts cardiac output to oxygen delivery to match oxygen demand. Oxygen delivery depends not only on cardiac output, but also on content. Therefore, cardiac output must be interpreted of what is appropriate for oxygen demand and also oxygen content, which is mainly determined by hematocrit and saturation. Let me close with a brief discussion of perioperative echocardiography. This is a huge topic. It's far beyond basic introduction to anesthesia, but you certainly should be aware of it, and you will learn much about it throughout your education in our department. Mainly I'm going to talk about 2D, but we also used it in the operating room, but we also use it in the emergency department and in the ICU. And we're also using transthoracic echo and 3D echo. The ASA guidelines is something you should be familiar with and have in your bibliography, in your list of papers, which is somewhat dated, but still is appropriate, and you should be familiar with it. Ultrasound, and although it means above hearing, but in practicality, we're talking about more than 1 million hertz or 1 megahertz, is unique in that it can penetrate tissues at a known speed of around 1,500 meters per second. It is reflected off of tissue planes back to the transducers, and based on the time interval, the computer can calculate the distance where the signal was reflected from and reconstruct an image. It readily passes through fluids, but not so well through spaces. This is a diagram of the scanners. In the past, they were electromechanical. Now they're electronic. They send various waves through the tissue, various beams through the tissue, and then reconstruct an image based on the reflection. We use both transesophageal and transthoracic. They're both based on the same physical principles. They give similar information. The orientation and views are a little different. Transesophageal has limited views. Transesophageal gives more detailed information because it's closer to the heart. It uses higher frequencies. Transesophageal is easily available to anesthesiologists, but it's somewhat invasive. And so we're also encouraged to learn transthoracic. And furthermore, we also use epicardial and epiaortic. It was first introduced to the United States by anesthesiologists, and it consists of an ultrasound probe mounted on the end of a flexible scope, which is introduced through the mouth. The probe can then be positioned in different positions based on depth and rotation and flexion and rotation of angle. This is a picture of the probe. It can be rotated. It can be moved in and out. The probe itself can be rotated. The probe can be flexed and twisted in various ways. It provides three kinds of data: 2D imaging, functional anatomy; color flow, direction of flow; and Doppler, velocity of flow. With this data, it can provide information about ventricular filling, ventricular function and contractility, valve function, anatomic defects, and detect myocardial ischemia and wall motion abnormalities. There are many views. This again is the ASA guideline summarized here. I'll just show a few of these views for your orientation, but not go into detail. We have the so-called 5-chamber views, which shows the right and left, the right ventricle, right atrium, left ventricle, left atrium, and outflow tract. That's the 5th. The so-called 4-chamber view, right atrium, right ventricle, left atrium, left ventricle, and the 2-chamber view, the left atrium and left ventricle. In the esophagus, you can see the aortic valve, the short axis view, the long axis view, and down in the stomach, you can see the short axis view, so-called donut view, and the long axis view. I'll just show a few of these views in closing. These are the mid-esophageal views. The standard 4-chamber view, and this is an echo image of it, concentrating on the left ventricle, left atrium, left ventricle, right atrium, interventricular septum, lateral wall, mitral valve. The 2-chamber view, left atrium, left ventricle, anterior wall, posterior wall. The long axis view, these are all long axis views, but this is called the long axis view. And it's characterized by showing the outflow tract of the aorta. I'm sorry, I'm inverted here. Shows old men make mistakes. So this is the left atrium, the mitral valve, the left ventricle, the outflow tract of the left ventricle, the aortic valve, and the aorta, the interventricular septum, the right ventricle, the anterior wall of the left ventricle, and the inferior wall of the left ventricle. In the transgastric view, you pass the probe down in the stomach and get a transverse view. And this is a transverse view of the left ventricle. Remember, the probe is in the back, so this is the inferior wall, anterior wall, septal wall, lateral wall, posterior papillary muscle, anterior papillary muscle, septum, and right ventricle. And if we rotate the transducer 90 degrees, you see a transgastric long axis view of the ventricle. This is the liver, the diaphragm, the diaphragmatic surface left ventricle, the papillary muscle, posterior papillary muscle, anterior papillary muscle, anterior wall of the left ventricle, apex of the left ventricle, and the mitral valve would be here. This so-called deep gastric view of the left ventricle. The probe is advanced way down in the apex and directed upwards. This is the apex of the left ventricle, the outflow tract of the left ventricle, the aortic valve, the aorta, the mitral valve, the mitral area here, and the left ventricle. These are upper esophageal views, a short axis view of the aortic valve, non-coronary cusp, left anterior cusp. A long axis view of the aortic valve, the anterior leaflet, most likely the non-coronary cusp, outflow tract, sinus of Valsalva, sinotubular junction, aorta. You can also get color imaging from echo. This uses Doppler, and based on the change in velocity of the frequency of the signal, determines whether it's moving. If it's moving, the velocity will change. If it's moving towards the probe, it's colored red. If it's moving away from the probe, it's colored blue. And you can then get images showing you where the blood is moving. Finally, you can use the Doppler to measure the velocity of the flow. And this is very important because from the velocity, we can calculate not only flow and calculate volume of flow if we know the area, but we can also measure gradients by this formula. The gradient equals the velocity squared times 4. This is used in measuring gradients through the aortic valve. And here we're passing a velocity probe, a signal through the aortic valve, and measuring the velocity through the aortic valve. It's going away, and so it's inverted. And from this velocity, we can calculate the gradient. The gradient is given by the peak velocity squared, which is 6 millimeters of mercury. We can also analyze the function of valves, and this is one measuring the velocity through the mitral valve. It's a powerful tool to teach physiology, to define hemodynamics and anatomic abnormalities, to facilitate diagnosis, to guide and evaluate therapy. And all graduates are trained to use basic echo. But it has limitations. It's difficult to become proficient. It's subjective. It's diversionary. It's usually only available while patients are anesthetized. There are hazards, and it's expensive. It's also used in the ICU, both transthoracic and with small disposable probes. The transthoracic, summarized here. And there are also small disposable probes that we don't have at UK, but you may hear about. These can be passed through the nose, be left in place for up to 72 hours, and can give reasonable views. The most important is the short axis transesophageal view, from which we can assess contractility and volume status. And that's the end of this presentation. Thank you for listening, and we'll see you later.